Hi, this is Michael Altos, and we're continuing our discussion about the endocrine system, diabetes, thyroid, and OB, and this is part 3. The first OB drugs we'll discuss are oral contraceptive pills. Usually these drugs have some combination of estrogen and progesterone, and estrogen is probably responsible for most of the side effects that we'll be discussing. Probably the most important thing you should know is the risk of thromboembolism, like a DVT or a PE, as well as perhaps myocardial infarction and stroke, and this is most common in women who take oral contraceptives together with being a smoker and being over the age of 35. So these may be risk factors we want to consider in our perioperative patients. Also, we know that oral contraceptive pills may present a problem for the use of sugammadex. And patients who use steroid-based oral contraceptives, or in fact any steroid-based contraceptive, should use a backup form of birth control for 7 days after receiving sugammadex. Now moving on to the care of the pregnant patient, the first substance we'll discuss is oxytocin or Pitocin. Remember that oxytocin is an endogenous hormone that exists in the body. We give oxytocin for many different reasons. First of all, it can be used to induce labor. You can start it at 1 to 2 milliunits per minute and titrate to contraction. Oxytocin is also the first-line treatment, the first-line pharmacologic treatment for postpartum uterine atony. After a baby is born, especially by C-section, the uterus can be boggy or soft, and bleeding can occur rapidly. In order to make the uterus firm and tight and stop the bleeding, Pitocin is often started, and many different protocols exist. Some of them are as simple as taking anywhere from 10 to 40 units and squirting them into a liter bag and running it in. At our institution, we have a more conservative protocol, which is a bolus of 600 milliunits per minute for 30 minutes, which is 18 units, and then continuing a long-term infusion at 60 milliunits per minute. We found that this drastically decreases the side effects, which include hypotension, flushing, tachycardia, and nausea. And it's been my experience that a significant portion of the nausea that we see in C-sections is due to large doses of Pitocin. The next thing we're going to discuss are other drugs used in the treatment of postpartum hemorrhage or uterine bleeding. The first is methylorganavine. Most people just call it Methergin. It's an ergot derivative which leads to constriction of uterine blood vessels and uterine smooth muscle. And it's usually used to prevent and control bleeding after childbirth or abortion, including a C-section. And it can also be used to expel retained products of conception after a missed abortion. The dose is 0.2 milligrams given intramuscularly. Side effects include hypertension, nausea, vomiting, cramping, and pulmonary hypertension. And this drug is contraindicated in patients who have severe preeclampsia or other pregnancy-related hypertension. Carboprost, commonly called Hemabate, is a prostaglandin analog that can induce uterine contractions and reduce postpartum bleeding, as well as trigger abortion. The dose is 250 micrograms IM, and its most common side effects are nausea, vomiting, and bronchoconstriction, and therefore it is contraindicated in patients who have severe asthma. And in general, at our institution, before we do a C-section, we identify which of these risk factors, preeclampsia and asthma, exist in our patients. So we know which of these two drugs is available in the case of postpartum hemorrhage. The last drug I want to discuss here is magnesium sulfate, which is not unique to OB patients, but we do see it used for a number of different indications. First, it's used for prevention of seizures in patients with preeclampsia and control of seizures in eclampsia. And just to define these terms, preeclampsia is the constellation of hypertension and proteinuria, which can progress to cerebral and visual disturbances, pulmonary edema, thrombocytopenia, abdominal pain, and liver dysfunction. Eclampsia is the onset of seizures on top of all of the previously described symptoms and signs. So magnesium sulfate is used both for seizure prophylaxis and for treatment, and this is due to the ability of magnesium to stabilize excitable membranes. Magnesium is a smooth and skeletal muscle relaxant. It inhibits release of acetylcholine, it reduces motor end plate sensitivity, as well as the amplitude of the end plate potential. Magnesium causes vasodilation due to its smooth muscle relaxing, and so patients may have flushing or sweating. And for this reason, magnesium is an effective antihypertensive medication. And since our preeclamptic patients also almost always have hypertension, the magnesium is effective to help lower blood pressure. Magnesium is tocolytic, which means it stops uterine contractions and is often given to patients who don't have preeclampsia but are having premature labor. And these patients usually lose their deep tendon reflexes while they're being treated with magnesium, starting at about 4 milligrams per deciliter. In fact, one of the normal things that our patients should be examined for regularly while they're being treated with magnesium is how are their reflexes. And if they've lost their reflexes, that may be a sign that you want to ease off on their magnesium levels. In the heart, magnesium slows transmission through the SA node and prolongs conduction time. And it's actually the treatment of choice for torsade. The dose is 1 to 2 grams as a slow IV bolus. If you have to administer magnesium, the loading dose is usually 4 to 6 grams given over 10 to 15 minutes, followed by an infusion at 1 to 3 grams per hour. The therapeutic serum level is usually 4 to 6 milligrams per deciliter, and the critical level is 8. Magnesium is cleared by the kidneys and should be avoided in patients who have myasthenia gravis, heart block, recent MI, or severe renal disease. Signs of magnesium overdose, as we have described, include hypotension and absent reflexes and weakness, also CNS depression, potentiation of neuromuscular blockade, and respiratory arrest. The treatment for magnesium overdose is calcium gluconate. That's it for our discussion about OB drugs. Please let me know if you have any questions, and we'll see you in the next round of videos.